Okay, so last time we left off with the remainder of practice questions, and I wanted to say before we move on, these psychiatry questions in UWorld and psychiatry questions on STEP in general are going to be doing their very best to confuse you into thinking of multiple different disorders at the same time. And it's always going to be those psych problems that have some overlap with them. So like adjustment disorder versus acute stress disorder, PTSD versus panic disorder, stuff like that. Now, a lot of these things, of course, can often have overlap in their symptoms, and some patients may have symptoms of both things where it really looks like they have both things. But what you need to be able to figure out is what is actually the root cause. For example, a person that comes and complains that they keep having panic attacks, but then they also mention in the question that they're scared of heights and that they recently maybe had a transfer in their job where now they have to go to the 15th or 17th or 30th floor on an elevator. Now this person is describing phobias, right? So then how do you figure out if this person has panic attack as the root problem, or do they have a phobia problem? What is their root issue? And that's going to be something based off of the clinical presentation in the question and whatever evaluation you can come up with. But you're going to have to think hard and figure it out, because chances are in this example that the person really just has a phobia disorder, and every time their phobia comes to realization, they end up having a panic attack, right? So you would not be picking panic disorder as the answer choice. You would be picking phobia as the answer choice. So always look for the root cause, the root issue. Another person may have PTSD, and every time they confront something that reminds them of that PTSD traumatic event, they get a panic attack. So once again, the root problem will be PTSD, not really panic disorder, and so on. So that's something you want to be very confident with. And as far as treatment goes, treatment you want to be very confident with as well, right? That's the only real medicine in psychiatry. The rest of psychiatry as a chapter is really just vocabulary, right? Knowing the definition of different disorders. There's going to be multiple treatments for multiple things all the time, right? Like for example, for ADHD, you can be taking a stimulant amphetamine, or you could be taking a non-stimulant atomoxetine, and they can both be answer choices. What would you pick? Well, it really is just up to you, up to what the patient's preferences are, and up to you. Because if the child's parents don't want the patient to be on a stimulant, then you would prescribe atomoxetine. Otherwise, you're just going to prescribe amphetamine and tell the parents that the child should be getting better soon, and then we can take them off the amphetamine. So multiple things that anything that has multiple treatments, you're gonna see multiple answer choices for them. And SSRIs are one of the mainstay of treatments for antidepressants, as well as you can see, many other disorders too, right? SSRIs like that single paintbrush that you can use to treat many issues. But SSRIs also carry some really interesting, keen side effects, and there's actual characteristics you have to know about them to differentiate them from each other, like how we talked about last time that fluoxetine is an SSRI with a very long half-life, so it doesn't leave your blood that quickly. So you need to remember that if someone's about to discontinue fluoxetine and start another serotonin medication, they need to wait longer than usual, right? Maybe wait a month. Paroxetine, on the other hand, has a very small half-life, and a lot of patients take paroxetine. If they don't take paroxetine for 2 to 3 days because they ran out, or maybe they traveled somewhere and they forgot to bring their medications, then since it has such a small half-life, it'll disappear from their blood real quick, and they'll get antidepressant discontinuation syndrome, where when you discontinue SSRIs abruptly, it presents with flu-like symptoms and tremors and really weird mix of symptoms that you would never really see in anything else. And so these are some key things that, of course, psych questions will do on CK. Step 1 psych questions were far easier because they were much more direct, where they really just wanted you to diagnose the problem or pick a medication. But in CK, there are going to be other things that are going to be involved rather than just diagnosing the problem or picking a medication. So here we have a question about suicidal ideation, and this is a patient with MDD with psychotic features. So remember, we said that any mood disorder with psychotic features, the word with should remind you that every time they have a mood disorder, every time they have a psychotic issue, it's with the mood disorder, that they never get the psychotic issue without the mood disorder, right? Then that would be psychotic features without MDD, right? That's not what this is called. This is MDD with psychotic features. Every time they get the psychotic feature or psychotic episode, it's with their low mood of MDD, right? If it's a psychotic episode that's always with a high mood, then that's probably someone with bipolar disorder, right? So BD with psychotic features would present with someone who has mania and psychosis at the same time every time, all right? So here I describe that all patients presenting with depression should be carefully screened for suicidal risk, as this screen is critical in determining the right treatment and setting and frequency of follow-up care. Before a treatment plan and setting are decided, it is essential to assess whether the patient is considering acting on a specific suicide plan. So in my psych rotation, this was a constant thing. Patients coming in with their follow-up appointment for depression, I had to ask them if they've had any suicidal ideation, and if they've got any plan, any intents, have they thought of things that they want to do to commit suicide, have they ever, and of course in their notes I would see, have they ever actually tried committing suicide, any attempts, right? Now, ideation, intent, and plan are the three things you ask about. Many patients will have suicidal ideation. It's pretty common, the fact that they've thought about, right? Thoughts of killing self, wish to die, right? Frequency, duration, intensity, and controllability are the key things you look for. How often? If they're thinking about dying every single day they wake up, that's pretty bad. As opposed to someone who once in a while thinks they should die. And then that's obviously a different severity. Ideation is concerning, and you want to annotate that into your notes, but that's not the worst thing. Now, intent and plan, those are far worse, right? So if they have intent, right, strength of intent to attempt suicide, ability to control the impulsivity, those are some things you would look for in the patient. Determine how close the patient has come to acting on a plan, right? Whether they've rehearsed it, whether they tried it but then they aborted the attempt, right? So sometimes you might hear a patient say, yeah, I actually did tie the noose around my neck, but then I canceled the jump and I didn't jump, right? Or maybe they'll say they went to buy rope but then they decided not to buy it, right? Now, it's not a common practice to go to buy rope. I've actually never bought rope, right? So it's not like a everyday shopping thing that people go buy rope. So when someone that's depressed has a history of going to buy rope, that indicates that they may be considering the rope for suicide, right? Something you want to keep in mind. If they have an intent, then this could require you to hospitalize them, hopefully with their permission, but if they don't agree, you may still have to hospitalize them against their will, right? And if they have a plan, then you definitely have to hospitalize them against their will, right? Specific details like method, time, place, access to how they're going to do it, and any preparation they've done, lethality of the method, likelihood of the rescue. These are all things you would consider. But intent and plan are case scenarios where you would basically hospitalize against their will. That's often an answer choice you have to pick, and you may not be very inclined to pick the answer choice, but other answer choices won't really fit the scenario very well at all, so you'll go with it. It's up to you to save them, and you have to, right? Because if you have, let's say this patient commits suicide, you could lose your license, because then they'll check the history and some lawyer is going to find out that that patient had come to see you as one of their last few appointments, and they told you that they were suicidal and you didn't hospitalize them, right? So it's not just about the patient, it's about you too. You want to save your license. You hear somebody say that they are planning or have some intensive suicide, you hospitalize them, period. You did your part. If they get out of the hospitalization and they go and then they commit suicide, no one can come after you, because you'll say, yeah, I did hospitalize the patient, but the patient got a little more better and then they left, and they didn't want to stay anymore. They refused treatment, whatever it is, you'll document, and then that's it. So here there's a question about MDD with psychotic features. Notice that the psychotic features only occur with the MDD. 72-year-old woman is admitted to the hospital because of worsening suicidal ideation for the past month. She has been refusing meals in order to sacrifice herself for the greater good. See, sacrificing herself for the greater good is not just depression, right? That's psychotic. She has stopped communicating with her family and spends most of her days sleeping or staring at the TV. She has been treated with multiple antidepressants in the past for recurrent MDD. So clearly she has MDD. Right now she's exhibiting some symptoms of MDD as well, where she's not really talking to people. 2 weeks ago, she discontinued taking venlafaxine because she felt it interfered with her plan to kill herself. She is 5 feet 5 inches tall and weighs 105 pounds, BMI 17.5. I'm not sure why they're telling you all that. Physical exam shows decreased skin turgor and dry mucous membranes. What's the best next step in her management? So clearly the venlafaxine that she's taking has not done the job for her. She's not doing any better. So ECT would have to be the next step. Okay. Her severe depression with delusions is consistent with MDD with psychotic features. Her condition is a psychiatric emergency because she is suicidal, refusing to eat, and has become dehydrated. First line treatment of psychotic depression consists of either combination of an antidepressant and antipsychotic or ECT. ECT works faster than pharmacotherapy and is often preferred to achieve a rapid response in depressed elderly patients who are unable to eat and drink, psychotic, or actively suicidal. Right, so they may have had other answer choices here which were antipsychotics, but keep in mind antipsychotics don't take effect for also, just like SSRIs, they take up to 2 to 3 weeks also to kick in. Right, all psych medications, generally speaking, take time to kick in. ECT would have immediate results the same day, where she would be more relaxed and hopefully less psychotic and less depressed as well. ECT induces a 30 to 60 second generalized tonic-clonic seizure under general anesthesia, so there's no pain. ECT is a safe and effective treatment for severe MDD and has no absolute contraindications at all. Anyone can get ECT done. It is typically administered 3 times a week, 6 to 12 treatments. In another question, the patient had MDD with psychotic features, but the answer was to treat with sertraline and risperidone. Right, so that's your SSRI and antipsychotic. She presented with worsening depression and delusions. She did not need ECT because that is reserved for patients who need a rapid response due to severe suicidality or refusal to eat or drink. And she's an elderly, frail woman who's already who's already dehydrated, right? So looking at how she's really light and pretty anorexic and she's not eating, that's why they're telling you all that, right? They're telling you her BMI because she's not eating and she's 72 years old. She may actually succeed in dying if she continues to not eat. Right, so that's kind of what you look for there. Next thing we have this one right here. So this one was a really interesting question because this thing, premenstrual dysphoric disorder, is actually taught in step 1 but not really taught. It's just mentioned. I taught it when we discussed it in the step 1 form section. I pointed it out and we talked about it, and it's in my videos, but it's not really something they teach in the book, right? So they have it written right here. They tell you that you can use SSRIs for premenstrual dysphoric disorder, but never in the book do they ever actually mention what that is. The name kind of gives it to you. You know, pre-MDD causes severe irritability, depression, or anxiety right before menstruation, and symptoms usually go away 2 to 3 days after the period starts. Patients who have significant dysfunction because of this issue can be prescribed SSRIs. So that's what we're going to see in this patient right here. A very rare thing in questions, but of course, being a rare scenario means that it's very possible it'll be a high yield topic for your step. Step loves asking about things that are considered low yield. 33-year-old woman comes to the office due to weight gain and low self-confidence. She says, I have always had trouble with my weight and mood swings. I have gained 20 pounds in the last 2 years and feel horrible about myself. I go through this cycle where I feel good, stick to a diet, and exercise for a couple of weeks, but then my mood gets really down. I can't stop eating junk food and feel so bloated. So you see she's mentioning going through a cycle, which of course should make you think of menstruation, and the word bloated should also make you think of menstruation. She's also upset about a recent fight with her best friend, saying, I blame myself because I'm much more irritable before my period starts, and I lashed out at her for no reason. The following week, I felt much better, but the damage was done. So you can see that she's describing literally what the issue is. Right before her period, she was irritable. After the period, she was better. So it's almost a sign. It's almost kind of like a PMS issue, right? She has struggled with moodiness and being overweight for most of her adult life. She says, I hate when I feel this way because generally I'm a pretty upbeat person. Physical exam and labs are fine. BMI is 29, so she's not really that overweight. What is the most likely diagnosis? Now, I'm not sure why people chose some of the things they picked, because that's, cyclothymic is somewhat respectable, but when you see this as an answer choice, I'm not sure how you can't pick it literally in a question that is based around mood changes that are affected by the period. right? Premenstrual dysphoric disorder was the answer. 20% of people chose cyclothymic disorder. This is in the field of dysthymia as well. Dysthymia was really long-term MDD. That's not as severe as MDD, right? Cyclothymia is really long-term cycling, which is long-term bipolar. So they have this long 2-year thing of having highs and then having lows, and it keeps alternating with maybe around 1 month or 1.5 months of symptom-free episodes in between, but never more than 2 months. That's cyclothymia. Remember, dysthymia is depression episodes happening for more than 2 years with maybe a little less than 2 months of symptom-free periods in between. So that cyclothymia, I could see the cyclical nature of her mood being up and down, but clearly cyclothymia is not really supposed to be related to menstruation, and her thing is she doesn't have mood swings that are happening without the period, so it's not bipolar, right? And binge eating disorder didn't make sense at all. She's eating junk food and then not eating junk food and whatnot, but it's not in a binge eating manner. Binge eating is not related to menstruation. Binge eating is only related to menstruation in the way where if the patient is kind of not really having a good diet, they may not menstruate, right? Especially in anorexia, they don't, anorexic females can lose their menstrual cycle. Binge eating disorder is a disorder strictly related to having episodes of binge eating a shit ton one day and then starving or using laxatives or causing vomit the other few days, right? Now, her cyclical pattern of overeating, mood swings, and irritability, which worsen prior to menstruation and resolve for a few weeks at a time, is suggestive of PMDD or PDD. I like to say PMDD. PMDD is a severe variant of PMS. So it reminds you of PM, so premenstrual, PMDD, and PMS, characterized by prominent mood symptoms, including sadness, mood swings, anger, anxiety, irritability, and decreased interest, as well as fatigue. Changes in appetite and physical discomfort, which decreases in intensity or resolve completely after menstruation, right? So that's kind of what you're looking for in all of these questions to make sense out of it. Mood changes in the premenstrual phase are common, requiring differentiation of PMS and PMDD from the premenstrual worsening of another medical or psychiatric condition, because patients who do have depression or psychotic issues, that does worsen premenstrually, but that doesn't look like it's her thing, because after her menstrual cycle goes away, she would go into depression or go into whatever her baseline feature is, but her baseline feature looks like it's just being upbeat and normal, right? So it doesn't fit any of those other diagnoses. However, unlike this patient who has 2-week periods of feeling good, careful history taking in a patient with persistent depression will show that depressive symptoms are also present outside of their menstrual cycle, right? Accurate diagnosis of PMDD requires prospective daily ratings for more than 3 cycles, demonstrating a symptom-free period in the follicular phase when they're not actually menstruating. Binge eating and bulimia nervosa are characterized by episodes of excessive, uncontrollable eating within a specified period that occur at least once a week for 3 months. That's not really what's happening with her. Bulimia nervosa also has compensatory behaviors like fasting, laxative abuse, or even trying to vomit, but that's not her issue. Okay, didn't really fit at all. We talked about mania and hypomania. We discussed bipolar 1 and 2. Right? We looked at all of that. We understood the differences between the two and how you're supposed to treat them. Right? So just for quick revision, we looked at it in step 1 where it was taught even better. But mania is the one with more severe symptoms. There's going to be psychosis on top of, well, actually this really doesn't do the job at all. So yeah, let me just go back over here. So mania, right, with your dig fast stuff, they're gonna have psychosis along with some of these things that you're seeing right here, right? Distractibility, grandiosity, very talkative. They don't need to sleep. They have tons of energy. They do all kinds of weird flight of ideas and weird plans, and you can see that in this patient right here, right? Hypomania though is a lot better. Hypomania doesn't have psychosis, doesn't need hospitalization. They will be really, really strong, don't need sleep, a lot of motivation, a lot of confidence, all of that, without the psychosis part. So it's like the better version of the two. So bipolar 1 is when you have mania, bipolar 2 is when you don't have mania, but both of them can have hypomanic and depressive episodes, right? So that's kind of what you look for to diagnose the issue. And lithium is the go-to medication. Now, lithium toxicity is a very high yield topic. A lot of things that lithium can mess up because of everything it kind of mimics. So if we go to pharmacology from here, we've talked about it in that lecture, and that lecture is also part of the Step 2 CK playlist. You have this lithium mnemonic for low thyroid, Epstein anomaly in the heart, insipidus for nephrogenic diabetes insipidus, and unwanted movement due to tremor. These are all things that can occur because of lithium toxicity. Right? You can see that in these two questions here, which help you understand lithium toxicity a little better. Point is that this is supposed to be excreted by the kidney, so it can really mess up the kidney. Has a very narrow therapeutic index, requires close monitoring of serum levels, almost exclusively excreted by kidneys, and most of it is reabsorbed at the PCT via sodium channels. So thiazides, NSAIDs, and other drugs. Other drugs include many other things like ACE inhibitors and most other renal medications in general. Any of these things that affect clearance, renal clearance, are implicated in lithium toxicity. So a patient taking lithium should have a very good functioning kidney with normal creatinine levels. Otherwise, you need to stop their lithium. All right. And you can see the issues it can cause in these two questions, where this patient was taking ECTZ, so that messed them up. And this patient, 37-year-old woman, comes to the physician because of increasing fatigue, irregular menstrual cycles, constipation. Any woman comes in with those three symptoms, you immediately think hypothyroid. She reports that she was prescribed a new medication by her psychiatrist, but she forgot its name. So you, as a good doctor, immediately know, oh, you must have been given lithium. Now you're presenting with hypothyroid symptoms. Neurologic exam further shows more hypothyroid shit like delayed relaxation and low deep tender reflexes. Which of the following medications is most likely prescribed by the psychiatrist? Lithium. Only 35% of people got this, and I'm not sure why. Like, maybe they forgot this, but lithium causes hypothyroidism. Okay, so a lot of things to really know in lithium. Very, very testable topic. So, excuse me, here we could see some CK questions about that, and then we have more things coming up. So, a 52-year-old man with a history of schizoaffective disorder is admitted to the hospital for treatment of a lower extremity cellulitis. He does not appear to have any other acute medical illness. He is continued on his home medications, lithium, risperidone, and sertraline. Wow, right? So he's got sertraline, which is an antidepressant, risperidone, which is an antipsychotic, and lithium for the bipolar aspect, mood stabilizer. Cephalosporin therapy is initiated to treat his infection. Okay. During the hospital stay, he also receives ibuprofen and acetaminophen for pain, and lorazepam as needed for anxiety and insomnia. His infection improves over the next 10 to 14 days, but prior to discharge, he develops repeated episodes of vomiting and diarrhea. That's strange, right? At the same time, he becomes tremulous and uncoordinated, which makes it difficult for him to walk without falling. So that's some level of ataxia. In addition, he seems confused. Vitals are normal. Physical exam shows fasciculations and bilateral tremor. What medication is most likely to have caused his new symptoms? Now, this is straight up going to be lithium. You know that he's taking lithium. You need to know the other two medications very well. Sertraline is only going to cause serotonin syndrome when mixed with other medications that cause serotonin retention. Risperidone, being the antipsychotic related to dopamine, can cause extrapyramidal side effects, but most notoriously, risperidone is known for causing potential nightmares and the hyperprolactinemia. So this is not hyperprolactinemia symptoms. That means that for some reason, starting cephalosporin may have caused some kind of lithium issue. And if you don't remember any of these connections that could possibly occur, you just think of whatever it might possibly be. And if you have no idea, you still just safely pick lithium. Usually if a patient is on lithium and something goes wrong all of a sudden, it's because of lithium. All right? The new onset of GI symptoms, confusion, ataxia, and tremor in a patient taking lithium suggests lithium toxicity. Lithium is a mood stabilizer used to treat bipolar disorder and schizoaffective bipolar type. It has a narrow therapeutic index and relies on adequate renal function for excretion. He likely developed lithium toxicity due to a drug interaction with ibuprofen, which is an NSAID. Right? Concurrent use of NSAIDs like ibuprofen can cause a decrease in renal clearance of lithium and lead to elevated serum lithium levels and toxicity. Other drugs that can increase lithium levels include thiazides, ACE inhibitors, tetracyclines, metronidazole. There's a whole list of them. So you won't know all the medications that can decreased lithium clearance. That's why if a patient has been on lithium and all of a sudden they're having weird symptoms because they did something new with new medications or new therapy or something, then it's probably lithium toxicity. Oh my god, okay. Next question here. History of elevated moods is the answer choice here, which right away should tell you that you're probably working with a depression patient and you're trying to see if they just have depression or do they have bipolar disorder. Because remember, if you give a bipolar disorder patient antidepressants, you'll get rid of the depression and you'll further exacerbate the mania or hypomania, which will lead to suicide. So 25-year-old man comes, 25-year-old woman comes to the office due to a 3-week history of depressed mood, loss of motivation, and oversleeping following the breakup of a relationship. She is sleeping 12 hours each day and describes difficulty getting out of bed and showering and dressing in the morning. Her concentration is poor at work and she has difficulty completing everyday tasks. Word text. She has no psychotic symptoms or suicidal ideation. She has a history of major depression, episodes at age 16 and 20. She was treated briefly with fluoxetine at age 20, but stopped the medication after a week as she did not like the way it made her feel. Following a rape at 22, she was treated with trauma-focused psychotherapy for 6 months. So she had PTSD, I'm assuming, and then she was treated for that. She has no significant medical history. She drinks a beer several times a week and uses cannabis approximately once every month. Physical exam is normal. After the physician discusses treatment options for depression, she chooses to have combination treatment with psychotherapy and medication. What would be most important to obtain prior to initiating pharmacologic treatment for her? So in this entire question, all she's described are depressive symptoms, right? And she has no psychotic or suicidal ideation, which they also mentioned. So what we need to do is ask her if at any point in history she's had mania or hypomania. Now, those are not the words you'll use. You'll ask her if she's had any moments that were not depressing, and she'll probably describe them to you openly. And that's when you figure out, oh, it looks like this is bipolar, right? So all antidepressants can induce mania, with the greatest risk occurring in patients with BD. Thus, prior to initiating antidepressants for major depressive disorder, all patients should be screened for a history of hypomania or mania to rule out BD. As many patients tend to minimize or have difficulty recalling periods of mood elevation, physicians should inquire about discrete periods of uncharacteristically good or irritable moods, excessive energy, decreased need for sleep, racing thoughts, risk-taking behavior. You need to actually dig in and ask these things, because they might not know that when they were doing this stuff, having racing thoughts and doing risk-taking behavior and not sleeping, that was mania, that was not a symptom of depression. They might think, a person that is not educated on bipolar disorder and psychiatry in general, which is the general public, they may think that their decreased need for sleep, racing thoughts, and risk-taking behavior were all symptoms of depression. So they'll tell you that, no, I've always been depressed. That's a lie, right? So you would have to dig in, like, hey, have you ever had a period where you had a lot of energy? Maybe you were, able to do everything throughout the day without any fatigue. And they'll be like, yeah, last month I signed up for this marathon. I did the marathon. It was really fun. We helped raise money. That's a sign of hypomania right there, right? And then another person might be like, yeah, last month I was working on this plan to end world hunger, and I was up all night putting together these diagrams, blah, blah, blah. That's a sign of mania, right? So the guy running the marathon was hypomania because he didn't do anything psychotic. He did a good thing, ran a marathon, raised money, blah, blah, blah. The guy that's making a plan to save the world from world hunger, that's mania, right? That's pretty unrealistic. And you would need to find those things by actually probing the patient. Otherwise, patients don't know what symptoms are not depression and what symptoms are depression. So you have to actually dig in really deep to get that. Here we see more. So 26-year-old man with BD1 comes to the office for a follow-up visit. He experienced his first manic episode 7 years ago and responded well to lithium. He became non-compliant with his meds after his condition improved and then experienced a second manic episode 9 months later. Over the next 5 years, that's a long time, right? 5 years. He experienced 3 additional manic episodes, 2 depressive episodes, and a suicide attempt. Since his most recent hospitalization for a manic episode a year ago, he has remained on lithium and had no depressive, manic, or hypomanic signs or symptoms. So that's great. You want to stop right there and tell yourself in your mind that lithium is his magic pill, right? Because in psychiatry, as we discussed earlier, not all medications work for everyone. So you have to see which specific medication did the job for that specific patient. He has no medication side effects, and lithium levels confirm that he is compliant, so they must have checked his urine. Today, he inquires about the possibility of discontinuing lithium, as he has been very stable over the past year and prefers to not be dependent on medication. Now, this conversation of, oh my God, I don't want to be dependent on medication, is a really unfortunate and pretty realistic conversation that many patients may bring up. And you'll have to let them know that being dependent on medication is not really something to be ashamed of. At the end of the day, you have a diagnosis. You can't just not be dependent on medications now. That diagnosis makes you dependent on medications. What do you mean you don't want to be dependent on medications? How are you going to get better? That's a very emotionally problematic thing a lot of patients go through. It's very common. You just have to educate them and sympathize with them, because it is unfortunate that they have to be dependent on medications now, but there's no other alternative. And if they don't comply with the medication, they may end up needing more medications to be dependent on later on in life. This is most commonly seen with chronic diagnoses like diabetes and hypothyroid, where the patient is going to be like, oh my God, I don't want to take insulin or glipizide for the rest of my life. I don't want to take levothyroxine for the rest of my life. And you look at them and be like, well, unfortunately, you have to. There's no other alternative. And you teach them in the least negative way, least offensive way, that this is their life now and they need to accept it. And if they don't abide, things can worsen, which will then put them under need for more medications. Now, in psychiatry, this is even more significant, because unlike levothyroxine and diabetes, where sure the patient could die, but it's going to be a very slow and progressive worsening of symptoms, in psychiatry, this guy can go commit suicide the next day, right? And not only commit suicide, he may actually end up killing someone else as well. So since he's been perfectly great on lithium, but gets all these episodes without lithium, he should never stop taking it. Right, so he's talking about wanting to quit, but you can't. There is a history of BD and a maternal aunt. What is the most appropriate recommendation for him? It was easy answer. Only 75%, at least 75%, and not 50% of people picked it, but still, it should have been like 90%. Continue long-term lithium maintenance forever. That's it. Multiple reasons he should do it. One, he's doing great on it, and two, he doesn't have side effects. Right? Those are the two usual reasons you quit a medication: if you're not doing great on the medication or you're getting side effects. 10% of people chose encourage patient to continue lithium for another year, then discontinue gradually. But why? Right? As soon as you encourage a patient to discontinue at some point in the future, they'll discontinue very close, not much far in the future. They'll discontinue maybe in like a month or two. That's just what happens. BD1 is a mood disorder characterized by recurrent episodes of one thing, mania. Both BD1 and BD2 also have major depression. BD1 is a lifelong illness that requires maintenance pharmacotherapy to reduce the risk of recurrent mood episodes. Most patients require maintenance for many years, and lifelong maintenance is indicated for those with a severe course, like him, with his frequent episodes, suicide attempt, severe symptoms, and even hospitalizations. He has had 7 mood episodes already. He's 26 years old. He needs to take this forever. Right? So the rest of the question also tells you about how patients struggle. Right? So patients often struggle with the idea of taking medications for their entire life, especially when they're young. A strong therapeutic alliance, psychoeducation, and adjunctive psychotherapy can help the patient accept the chronic nature of illness and enhance adherence. If this patient insists on stopping lithium, the first step will be to try to cross-taper to another anti-manic agent like valproate, lamotrigine, or quetiapine. If he refuses all pharmacotherapy, lithium should be slowly tapered off over weeks to months and frequently monitored to identify early signs and symptoms of recurrence. Now, monitoring that is nearly impossible. You know, how are you going to monitor him? No one has a camera on him, and he's not going to necessarily, you know, you're depending on him to come back to you every time he feels like shit, and that's assuming he didn't die, right? So at the end of the day, you have to make sure you annotate the fact that the patient has actively refused treatment, right? Where you can still continue sending their prescription until they say no, 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 right? Until their final refusal, you could still send prescriptions, and that'll show logs as proof that you were sending the prescription. The patient declined it. Then, you know, if they die after that, it's not on your hands, and that was just the decision they made, and it's very unfortunate, right? Continuing treatment for an additional year with subsequent discontinuation is actually contraindicated in him, as it would result in relapse and he can die, which is pretty obvious from the question. Now, this is a question here where the answer was actually adjustment disorder. So, 18-year-old woman comes to the office due to difficulty sleeping and worry about her grades. She started college 2 months ago and is living by herself for the first time. So 2 months, okay? For the past months, she has been increasingly anxious that someone is going to break into her apartment, despite the fact that she lives in a safe neighborhood. She frequently lies awake in bed, fearful that any sound could signify an intruder. And on several occasions, she has gotten up in the middle of the night to double check that the front and back doors are locked. Alright. When she finally falls asleep in the early morning hours, she sometimes has nightmares that an intruder is breaking into the house. She feels tired all day and is worried as her lack of sleep is beginning to affect her studies. She feels tense all the time and has been avoiding socializing with her friends due to feeling exhausted. What is the most likely diagnosis? So, since it never really broke 3 months and almost all her symptoms are related to some not really well justified anxiety issue, it's just adjustment disorder, right? Her new stressor was moving, right, because of college, and nothing else really fits. It can't be GAD because that would require to be more than 3 months of symptoms, right, and passing the 6-month period like that. And it's definitely not OCD because she's not doing any obsessive or compulsive things, right? Needing to check is one thing, but needing to check because you have some reason is another thing, right? So that's OCD patients don't do something for some valid reason. They do it because that's their ritualistic mannerism of doing it, right? Her anxiety and insomnia stem from her adjustment to living alone for the first time. In turn, her symptoms of tension and insomnia are starting to negatively affect her studies. An adjustment disorder involves emotional or behavioral symptoms developing within 3 months of an identifiable stressor and lasting no longer than 6 months. Once it passes the 6-month period, it would be considered generalized anxiety disorder. Symptoms are distressing and impairing, but do not meet criteria for another mental disorder. Stressors can be single or multiple. In her case, they are multiple: moving away from home, living alone for the first time, and college. GAD is the same thing but lasting more than 6 months. And OCD is preoccupied with orderliness, perfectionism, and control, which she doesn't have. I remember OCD is the person you can't date. Can't date somebody who's OCD because they're going to control you to be just like them. As opposed to OCPD, where it's kind of their personality, but they understand that it's just them. You know, it's just them. Not everyone has to do it. Here we're looking at a very interesting answer choice that maybe you may not know of, but it was pretty straightforward for this question. So 80% of people did get it right. 26-year-old woman, G1P1, so she's pregnant, comes for a 6-week, G1P1, comes for a 6-week postpartum checkup following an induction of labor and vaginal delivery at 38 weeks gestation for preeclampsia with several severe features. So she was pregnant, she just gave birth, it's been 6 weeks. Her pregnancy was otherwise uncomplicated and she has no chronic medical conditions. She's currently breastfeeding and supplementing with pumped breast milk. She has now resumed her menses and is taking a progestin-only pill for contraception. Okay, so all of that is great. She says the baby is healthy, which is great, but I haven't been sleeping much and have been very tired. Totally normal. No one gets to sleep when an infant is around. My mom is coming to stay with us, so I'm hoping to get some rest soon. Vitals are fine, everything else is okay. Breast and pelvic exam is normal. What should be performed at this visit? So everything's actually normal in this question. She's got no bad symptoms and nothing out of whack or any red flag issues. You should perform the Edinburgh Postnatal Depression Scale. Remember that postpartum blues, postpartum depression, and postpartum psychosis are a thing. Postpartum blues are the most common thing, and they occur very soon, like within the first 2 weeks, within the first week, if anything, of giving birth. She's way past that. So now she could be going through postpartum depression, and we need to give her the documentation to take that little test and check if she has symptoms of postpartum depression. Right? The Edinburgh Postnatal Depression Scale has a 90% sensitivity, so it can rule out something where the patient is not depressed. Women with a positive screen for postpartum depression require further evaluation, possibly with thyroid function test, the other thing people chose, treatment, and close follow-up. This is sensitive, so the snout mnemonic, it rules out depression when it's negative. If it's positive, you have to do further evaluation to see are they actually depressed, right? And why they're depressed. Next thing here, this one is bipolar 2, but people were confused. A lot of people chose bipolar 1 as an answer choice. Should not have happened. This should have been 100% everyone choosing bipolar 2. 53-year-old man comes to the office due to depressed mood, low energy, and poor sleep for the past 2 months. Although he spends up to 12 hours a day lying in bed, he gets only 4 to 5 hours of sleep and never feels rested. So that's some level of depression symptoms, right? He's isolating himself from family and says, I eat only because I have to. So all of this looks pretty depressive. He has had several previous periods of depression, but was never diagnosed or treated. He also had periods lasting 5 to 6 days at a time in which he gets bursts of energy, tons of new ideas in my head, and feels great. During these times, he likes to work extra long hours to take an additional project at work, and he feels well rested despite sleeping only 4 hours a night. Now he fears his depression is having a major impact on his work and family life. He has been uncharacteristically procrastinating on several projects and is often late to work. He lacks motivation to spend time with his kids or friends. He has increased his daily caffeine intake to 6 cups of coffee a day and has an energy drink to counteract his fatigue. He recently started using marijuana at bedtime to escape his depression and help him sleep, which is a pretty normal, common thing to do. Mental status exam shows slow speech, sad affect, no suicidal ideation. Most likely diagnosis here is clearly he was going through hypomania. He didn't become dysfunctional, nor did he ever show any psychosis. Right? He had a bunch of ideas and he had a lot of energy and didn't need to sleep, and he started working really, really hard at his job. Those are all good things, right? There's nothing really bad about that, nor is any of that psychotic, right? So we're not gonna give him some kind of trouble for any of that. Those were hypomanic symptoms. So it's BD2. Had he done something manic, psychotic, then it would be BD1. And so that's the major differentials you would be doing between BD1 and BD2, and then of course cyclothymic, which is bipolar for 2 or more years with no more than 2 months in between ever where they were completely symptom free, right? And that's the full breakdown in that URL table. Good question right here. This is another very straightforward question right here, which is going to be related to what we're looking at next, which are our personality disorders. Great topic. One that's very difficult for many people because a lot of answer choices often feel like it is supposed to be a personality disorder and you'll be very inclined to pick it, but the answer is not a personality issue. That the question is not about personality disorder at all. So here what we're seeing is a 21-year-old woman with borderline personality disorder comes to the clinic because she has been increasingly angry and reports hearing voices telling her to hurt herself. So right away, those are signs that are psychotic, right? There's no denying that when you're hearing auditory hallucinations, that's a positive symptom. That's psychotic. She's convinced her mom is plotting to kill her, which is paranoia. In addition to lithium, which she takes for her mood stabilization, what else should be added to her regimen? An antipsychotic, obviously, right? So it's a great question, very straightforward. Never make it more confusing than this. Never. This question will only be confusing because you're going to look at the list of answer choices before you even thought of the fact that she needs an antipsychotic. And you'll see a lot of answer choices there that are going to be somewhat antipsychotic, some antidepressants, some completely unrelated. And you're going to have to pick the best antipsychotic for her. So this is a typical antipsychotic that will do the job for her. And that's it, straight up, right? Atypical antipsychotics may be answer choices too here, but atypical antipsychotics are for schizophrenia. She doesn't have schizophrenia, at least not yet. We don't have enough in this question to diagnose her with schizophrenia, which literally requires more than 6 months of symptoms, right? There's the 1 month thing is brief psychotic. In between is schizophrenic form. More than 6 months is schizophrenia. We don't have that here. So you don't pick an atypical antipsychotic as an answer choice. You're looking for a typical antipsychotic. Haloperidol will be the best one. You see that, you pick it, you move on. Now, our next topic are our personality disorders, which I've discussed really well in the step 1 lectures. So we'll look at it in both places together. Generally speaking, though, personality can be defined as an individual set of emotional and behavioral traits, which are generally stable and predictable. Personality disorders are defined when one's traits become chronically rigid and maladaptive, leading to social or occupational dysfunction. Here we're going to have all the disorders, and the key thing to keep in mind is oftentimes you're going to get questions where patients are doing something weird and they'll have personality disorders as an answer choice. But if they just started doing the weird thing, maybe a month ago, 2 months ago, if they just recently randomly started doing that weird thing they're doing, it is not a personality disorder, because personality is inherent. It's been a part of you for a long time. And in a personality disorder, whatever the disorder is, has been a part of them ever since they were whatever young age, 16, 18. So if you get a 32-year-old patient today who 2 months ago started doing some weird thing where they're dressing up weird, schizotypal personality disorder is going to be an answer choice because they dress up weird. But this can't be a person who has schizotypal personality disorder. You don't develop a personality at age 32, right? Especially not a pathological one like that. So this must be a person who's going through some level of psychosis, possibly brief psychotic disorder or schizophrenic form, depending on what the time span is. And that's something that will really save you a lot of time. Cross out all the personality answer choices if the question is about someone who just started having some new onset random shit symptoms, because personality does not develop at those ages like that, right? So the general summary is right here. You have cluster A, which are odd and eccentric, cluster B, which are dramatic and erratic, and cluster C, which are anxious and fearful, right? You can come up with your own things for memorizing these as perfectly as possible. I'm going to share with you what I did. So cluster A has paranoid, schizoid, and schizotypal. Paranoid, straight up, we all know what paranoia means. Why are you being so paranoid, right? Suspicious, distrustful, hypervigilant. Schizoid is like an android, like a robot. Prefers to be alone, is very detached, has no emotions. And schizotypal is someone who's kind of sort of schizotypical, right? Schizotypal sounds like you're a schizophrenic type of person. So they have unusual thoughts, unusual perceptions, unusual behaviors. They also dress up weird, but they're not psychotic. They're not psychotic. They don't have positive symptoms. They may have a few negative symptoms depending on who they are, but overall they're fine. They're perfectly fine. They have jobs. Remember, everyone in this group, right? Every single one of these people, they're not psychotic. Keep that in mind. None of these people are psychotic. These are personalities. That means that these are people that are working, making money, living their life, having relationships, all of that perfectly fine. They're functional. Everything's good, right? It's just that they go through certain distresses depending on what their personality is. Cluster B has the most distress. Antisocial personality disorder is a person who can never socialize with anyone, and you won't want to socialize with them because they have disregard and violation of the rights of others. Straight up, right? Borderline personality disorder is someone who has this practice of splitting, right? They have chaotic relationships, abandonment fears, labile mood, dependence on their abusive spouse or something, impulsivity, inner emptiness. And the splitting act is where they can say all of these people are good and all of these people are bad, and that's something that they'll often do. Histrionic is an answer choice that you may not have used much. It's not a word we say every day. Histrionic is someone who is superficial, theatrical, and attention seeking, right? They love getting attention. Very common thing in today's time. And then there's narcissistic, which is a pretty commonly used phrase. We say stop being narcissistic because that's a person who thinks they're the shit, right? They're the best. They're the most amazing thing. Grandiosity, lack of empathy. They're too good for everyone. Cluster C, not much stress here, but it can happen. These people have anxiety and fear, and these things are going to be answer choices when you have general anxiety disorder or adjustment disorder as answer choices too. Avoidance due to fears of criticism and rejection is avoidant, straight up, right? Very good word. Dependent, also straight up and very good. Submissive, clingy, needs to be taken care of. Now, be able to differentiate between dependent and borderline. Borderline is also dependent. They are dependent and they really, fear abandonment. They don't want to lose their spouse, even if their spouse is abusive. But there's a clear difference between the two, where borderline, these people are going to be having really bad problems, really significant issues in their life. Whereas the dependent one is just someone who's very clingy and needs to be taken care of, but they're not going through self-harm or emptiness or impulsivity. And then the last one, OCPD, which is ego-syntonic obsessive control, right? They have obsession and compulsive problems that they take care of by themselves, but they won't force it onto you. They realize that it's their personality. They're a perfectionist, but that's just how they are. It doesn't mean you have to do it too, right? So that's a grand summary of these things. You should be able to run through that very quickly, very easily. So back in step one, I talked about these guys a lot more. Here we can see they gave some nice examples as well. So for paranoid, I used characters for each one of these. I used different characters to describe the personality group because these were the characters I felt best fit. For cluster A, I went with the Tin Woodman of the Wizard of Oz, right? So he's clearly a robot, so he works with the schizoid aspect. He doesn't have any emotion, so he's got that lack of emotion, and he didn't need people. He didn't need anyone, so he was perfectly okay being alone. He's also dressed weird, so he fits the schizotypal eccentric appearance, and he did have some odd beliefs because this was a magical movie. And then the pervasive distrust of accusatory from paranoid, well, he was definitely very paranoid because the reason he turned out like this was due to a witch that made him that way. So now he was paranoid of everyone, right? He was paranoid of everyone. He was paranoid of being watched. He was paranoid of other people who may be witches, and so on. He perfectly fits what a cluster A personality encompasses. So that's what we're going to see here, right? Paranoid, distrustful, suspicious, interpret others' motives as malevolent. Everyone is out to get you. Note, these patients will use projection as a defense mechanism. Right? Projection, if they find someone that, well, if you forgot what projection is, it's the term projection means to project yourself onto someone else. So if you find someone is doing something bad, or if you think something bad is happening, you'll just project it onto someone else. So that's like right here. Right, projection, attributing an unacceptable internal impulse to an external source. So if you think someone is, if you yourself have the impulse to cheat, like this example right here, then you'll just call the other person a cheater, right? This is something they do. They're so distrustful that they'll project their own decisions onto someone else. If they think they want to kill someone, they'll say, you want to kill me, don't you? And just project that thought onto the other person. 59-year-old man who lives alone constantly feels that his neighbor's children are spying on him and plotting to break into his home. He has installed security cameras all around his property to obtain proof. He feels he cannot trust the police to do a good job because they will probably take the side of his neighbors. Right? And again, this is just someone being paranoid. It won't fit any of these other issues. Schizoid, isolated, detached loners who prefer to be alone. Not that they're alone because no one wants them, they prefer to be alone. They also have restricted emotional expression. So 66-year-old man who moves to Thailand alone after retirement, has no desire to remain in contact with his family, is very distant in his interactions, stays in his remote accommodations without unnecessary travel, and does not crave interaction with the locals either. He just wants to be alone, and that's perfectly fine. This is normal. You may not like it, but it's normal. Anyone can do this. It's okay. There's nothing psychotic about it, nor is he depressed. He's just doing what he wants to do. So you see how personality disorders are going to be very different from other answer choices. You're not going to pick MDD or dementia or any of those things for this patient. And the initial thing I said, remember, personality disorders don't develop in a month or two. But all your psychotic disorders have time periods to them. Schizophrenia, 6 months. Schizophrenia from 1 to 5 months. These things have time periods. Adjustment disorder and GAD, 3 to 6 month thingy, right? PTSD and ASD with their 1 month period. So if it happened, if whatever happened to the patient happened within some time period, it's probably not a personality disorder. Personality disorders are something that happened forever. It's been happening for the longest time. They've always been that way. So, it should help you eliminate a bunch of answer choices from your test, which is freaking awesome. Last thing here is schizotypal. Odd behavior, perceptions and appearance, magical thinking, ideas of reference, right? Remember, in contrast to OCD, these patients do not feel their behavior is problematic, right? Ego-syntonic. They also do not have true obsessions of wait, why is this here? Oh, this is definitely an error. That's supposed to be only over here. Let me just remove that. That's definitely a book error that they made. This note has nothing to do with schizotypal. So that gives me a little bit of space to fit something there. What was that? Yeah, so just they're just weird. They're just weird like that. Tin Man from the Wizard of Oz thing. That's it. Right? Odd behaviors, perceptions, and appearance, making magical thinking and ideas of reference. That's it. So here you have a 35-year-old man with very strange ideas regarding the importance of crystals and their effect on health. Okay. He meticulously mines and collects crystals, feeling that they will one day prevent him from acquiring cancer. Again, this isn't so far-fetched. If he believes that there are certain crystals out there that can make health better and prevent cancer in him, then that's okay. That's fine. People believe all kinds of things can help. And we all have things that we eat or drink or pills that we take that we think will help, right? This is equivalent to people who take certain pills because they think it'll help them lose weight, right? At the end of the day, the only thing that'll really help you lose weight if you're trying to lose weight is a calorie deficit diet. That's it. That's the only one thing 100% confirmed to help you lose weight. Otherwise, other than that, you could do whatever you want to, exercise all you want, take whatever weight loss pills and supplements you want. Will they help possibly lose weight? Maybe, but it's really just a schizotypal belief. That's all it is, right? So a schizotypal is not psychotic. It may look a little weird, but it's not, right? It's weird, but it's not psychotic. Okay, so that's one of the key things I want to keep reiterating, because you're going to be given answer choices with patients who are going through psychosis, but they're going to have these answer choices there, right? So eventually I'm actually probably going to move these images over here too, and then annotate it into this book as well, because it honestly is like my best thing for teaching this. So I'll put it all in here somewhere too. For cluster B, now we're looking at, the easiest thing to come up with cluster B was Cardi B. Cardi B easily can be imagined to encompass borderline, histrionic, narcissistic, and antisocial personality disorder. I'm not saying she's a bad person or anything. It's just the way she carries herself is very intriguing, right? She is an actress. She acts. So the way she acts is obviously what gets her fame, and it's perfectly fine that she acts the way she acts, but we're talking about how she acts here, right? The way she acts is what gets her fame, and she does, without a doubt, act very wild, right? So we have borderline right here: unstable mood, relationships, and self-image, feelings of emptiness, very impulsive, history of suicidal ideation or self-harm are possible. Note these patients often employ splitting as a defense mechanism, right? So we're seeing a 28-year-old woman presents to the clinic after having praised her new clinician as better than all others. That's splitting, right? This is the best clinician in the world. She reveals that she fired her last therapist as he was not really helping. You notice she has fresh cuts in a row on her forearms, which are suicidal attempts. So that's a borderline personality person. Borderline is very often similar to bipolar, so you have to be careful in which answer choice you pick, right? And there's more breaking down in here, right? So borderline personality disorder, pervasive pattern of unstable relationships, self-image and affects, and marked impulsivity, with 5 or more of the following that first aid didn't have space to talk about apparently. So frantic efforts to avoid abandonment, unstable and intense interpersonal relationships, markedly and persistently unstable self-image, impulsivity in areas that are potentially self-damaging, recurrent suicidal or threats of self-mutilation, mood instability, which will often make it look like bipolar, but what they have here is mood reactivity, which means that when they hear good news, they get really happy. When they hear bad news or when they hear negativity, they get really negative. Chronic feelings of emptiness, inappropriate and intense anger, and transient stress-related paranoia or dissociation. These are some key things you'll be looking for. And remember, this is a personality disorder, so this change should not be something that recently happened. If a person suddenly started acting this way out of nowhere, that's probably some kind of other answer choice. If they've always been like this, then it's borderline personality disorder. Next thing, histrionic, excessively emotional and attention-seeking, sexually provocative, and theatrical. So you can see how all of this is somehow you can imagine things that are related to Cardi B. 35-year-old woman presents to the clinic wearing a very low-cut blouse with a lot of cleavage, adjusting her position to draw attention to herself. When she does not get attention, she breaks into tears, saying that no one notices her, not even her friends. This can often very much look like borderline personality disorder, right? But it's not. This is not just someone who is doing something reckless or having suicidal behavior, or just, worried about being alone. No, this is attention seeking. It's straight up attention seeking. You need to look at the root thing in the question. Is the patient trying to seek attention, or is it one of this group of things? They may have some of these things, like an unstable mood, maybe they have relationship problems, but if mood seeking, attention seeking is the thing they're doing, that's histrionic. Histrionic is attention seeking. Narcissistic is the person that thinks they're the best, right? Grandiose, needed admiration, have sense of entitlement, lack of empathy, right? 45-year-old man, and of course they use a man as an example here, right? Because this is usually going to be seen in men. Very common, very cultural thing. A lot of men are very narcissistic. 45-year-old man sits impatiently tapping his foot in the waiting room of your office. He approaches the receptionist, demands to know where the doctor is, and tells her that he will have her fired and the doctor reported if he is not seen shortly. So he thinks he owns the place, right? That's narcissistic. You are all wasting his time. He lacks empathy as well. You're also going to see that the person that is narcissistic will be the person that will not really understand someone else's pain. They don't care. It's all about them. Last thing, antisocial personality disorder. Very important to understand that this does not mean someone who likes to be alone. The word antisocial is thrown around in society all the time. Oh my God, why are you so antisocial? A person that is antisocial, personality disorder, does not mean that they are just an introvert. Being an introvert is not what makes you antisocial. Antisocial personality disorder is antisocial. These are people you will never want to socialize with, right? The one that doesn't want to be alone, that's going to come later on. That's dependent. The person that never wants to be alone, right? Antisocial personality disorder is not the person that doesn't want to be alone, or likes to be alone, right? Antisocial personality disorder, often people will think, oh yeah, antisocial. He doesn't want to be with anyone. But we saw that in schizoid. This is the person that doesn't want to be with anyone, right? So there's a bunch of differences that you can kind of sort of confuse yourself with. Don't do it. An antisocial person is a person you don't want to socialize with because they violate rights of others, violate social norms, and violate laws. They're terrible people. Must be over age 18 to get this diagnosis. Before age 18, this was known as conduct disorder. Remember? Doing bad conduct will get you in jail. That was the mnemonic for that we talked about for childhood issues. So now, if that persists into adulthood, they are now definitely going to end up in jail because they're going to violate shit, and that's not going to work out. So here you have a 22-year-old man who was in juvenile detention for theft as a teenager and presents to your office now via court order after a brutal assault. He says that he does not need to be seen by a shrink and that the victim offended him and deserved the assault. Right, so he's being rude by calling the court people a shrink, right? It's a slang thing, and he's saying that the other person deserved being offended. So you could see in him, he's not psychotic. You might think this is kind of psychotic of him to do, but he just has anger issues, right? He's not psychotic. He doesn't have psychosis, no positive symptoms. He just has really bad anger issues. That is an antisocial person, right? You don't socialize with people that have abrupt anger issues. Fuck that. Last thing we have here is cluster C for Cooper, Sheldon Cooper, in the show Big Bang Theory. Right, Big Bang Theory, that's him right there. In the show, he's an intelligent physicist who comes up with all kinds of things. He works on a lot of things throughout the show. He lives with 3 men, which are his roommates, and all of his characteristics fit perfectly into these things. So he is very OCPD, right? He'll never force the other 2 to do things the way he does it, but he'll fix things that they do because he didn't like the way they did it. Okay, so OCPD, preoccupied with perfectionism, order, and control at the expense of efficiency. It may take longer to do something, but he'll make sure it's done the perfectionist way. Inflexible morals and values. He doesn't want to change how he does it. Remember, in contrast to OCD, these patients do not feel their behavior is problematic, right? Egocentric. They also do not have true obsessions and compulsions. Right? So OCPD is just a personality. They just do their thing, and they're not going to really mess anything up. It's okay. 35-year-old woman presents to your office at the request of her boss, who feels she is too focused on minute details on team projects and does not allow others to participate for fear of unwanted errors. She does not see anything wrong with this style of work, as she believes her coworkers cannot be trusted to pay adequate attention to detail. Right? So, egosyntonic. They believe what they're doing. Right? In contrast to OCD, these patients do not feel their behavior is problem. Egosyntonic. They actually think that what they're doing is the best way to do it, and they do it just like that. That's him. Remember, in OCD, which ends, it's not a personality disorder. So since it's not a personality, they know it's a disorder. So in OCD, they know ego dystonic. They know that what they're doing is excessive, but they have to do it like that. They have to do it like that, right? So OCD versus OCPD, make sure you can differentiate between the two. Very, very critical little differentiation that you need to never really mess up, because that's pretty, that's a pretty easy thing to get your easy points on. No reason to really mess that up. Let me see where OCD right there. Right, so OCD right here, obsessions that cause severe distress, relieved in part by compulsions. You're gonna have to look for those things. The personality guy doesn't have obsessions and compulsions. Ego dystonic behavior is inconsistent with one's belief and attitudes, associated with Tourette syndrome as well. Most people who have Tourette syndrome will have OCD, and patients with OCPD is different. Okay, so people with OCPD feel their obsession is right, and the world should ideally act their way. Egosyntonic obsession, really big issue. So at the end of the day, which one is better? We keep talking about it. So Sheldon Cooper does actually end up getting a girlfriend in the show, but it's a girl that's just like him. Most of his life in the show, he actually spent single. That's because you cannot date someone whose personality is shit, right? We all say this. What do we look for? Number one characteristic for our spouse? A good personality, right? So if you have a shit personality, which then of course any one of these things, all of these things are bad personalities. These are not good personalities. So OCPD is a bad personality. You can't date that person, right? This is the person who believes that the way they're doing it is the only way to do it, is the perfect way to do it, and anyone else that wants to do it in another way can fuck off. Which is what this woman here is doing, and that's why she's here to see a psychiatrist. Right? And OCD, which is a disorder, it's just a disease. We date people with all kinds of diseases. We get it. It happens. Everyone has their flaws. That OCD person you can date, they're going to have their own obsessions and compulsions, and they may even take medications to eventually get control of it, but they're not going to force their obsessions and compulsions onto you. Right? It makes sense. They're not going to be like, you need to be obsessed with this too, and you need to be doing this weird compulsive behavior too. They're not going to do that to you. So you can date an OCD person, but you can't date someone with a shitty personality. That's this, right? Now, avoidant. So although he's a super intelligent person, and he comes up with all kinds of physics breakthroughs and whatnot throughout the show, I just told you that he literally lives with 3 other people, right? He lives with, two other men in the same house. He has an avoidant personality, though. Although he lives with them, he doesn't really do anything with them. He doesn't ever go to parties with them or choose to take them out or go out with them. Very minimal, almost never does anything with them. And one of his key things in the show, that because it's a comical show, is his rejection sensitivity. Every time he talks about something really intelligent, when people tell him, oh, well, there's an easier way to do it, or something has already been discovered, I don't know what you're talking about, he gets depressed as fuck. He gets really sad, and he'll go lock himself in his room, and he'll mope about it a little bit because you didn't give him the praise he wanted, right? Fear of being disliked or ridiculed, yet desires to have friends, which is the opposite of avoidant versus schizoid is a thing. Remember, schizoid people don't even want friends. They're happy being alone. Avoidant is socially inhibited but still wants to have interactions. He'll go with the other 2 boys for dinner and stuff, but he's only going to eat. That's it. He wants to be with people, but he's hating the whole event of being at a dinner. So it's very strange personality. 33-year-old man stays at home to avoid an office party as he fears having to make small talk, right? He wants to go, though he is more afraid that he will be inadequate or rejected by others. See, the difference from schizoid is that he wants to go. A schizoid person doesn't want to go. The schizoid person just wants to live in Thailand without anyone, and they're perfectly happy like that, right? Last thing, dependent. Big time Sheldon Cooper. Submissive, clingy, and feels a need to be taken care of. When he finally gets a girlfriend, that is when it shows the most. She gives him pretty much all of these things. She lets him, be clingy. She takes care of him, and she answers everything he does, and She supports all his things that he's doing. He has a lot of difficulty making decisions, but the only reason he dates her is because she's just like him. So if anything, she helps him make the decision that he himself already wanted to make, but he was just being a loser about it. And they often do feel very helpless because when they don't have the person they want, they get really down. Right? 30-year-old woman presents to your office in crisis, saying that her parents just kicked her out of their house and she is struggling to survive on her own. She says she cannot make her own choices at the grocery store, as her mom would always care for her, and now these decisions are overwhelming. She has been sitting outside of their house daily, hoping they will get her. They will let her live there again. Right? Very very clingy, very very helpless. It's very unfortunate stuff. Okay, so if you've never seen Sheldon Cooper, you can definitely take a little break and check out some clips of Big Bang Theory on YouTube, and you'll get to understand his personality very quickly, and you'll see the personality in action. You'll see him being OCPD about things, fixing things around the house and all that. You'll see him being avoidant and not really wanting to be a part of anything, yet at the same time kind of wanting to be a part of everything. And you'll see him being very dependent, needing needing reassurance, needing love, needing affection, needing care. Okay, so that's generally it for all of them. Now, a lot of them do have defense mechanisms, as we saw here. For paranoid, they had projection as a defense mechanism. For borderline, they had splitting as a defense mechanism. These are things that can pop up in answer choices, and you have to catch that, right? And let me see, was there anyone else? No, that's about it. Defense mechanisms are methods of dealing with anxiety or conflicts of the ego. These can be immature or mature. Immature defense mechanisms are common in personality disorders. Important defense mechanisms are going to be talked about next. For diagnosing personality disorders, diagnosis is clinical and detailed history is taking is imperative. Collateral information may be helpful. Patients typically deny or do not realize that they have a problem. All personality issues are egocentric. It is your personality, so you think that's the way to be and it's perfect. It is not a disease, it's a personality. Right? So get that in your head and it'll hopefully make a lot more sense at that point. Best initial treatment for all of these is just psychotherapy. Whereas the actual disease, you give medications, right? Like when we looked at OCD here, you actually give SSRIs, clomipramine, or venlafaxine, which is an SNRI, to help. So, with the personality stuff, you don't need medication. It's a psychotherapy. They need to understand what's happening and why they're acting the way they are, and it's not okay. If we look at these two things, real simple, straightforward questions. 19-year-old man takes an overdose of diazepam when his girlfriend leaves him. He has been using cocaine occasionally and visiting prostitutes as well. He has violent mood swings and he keeps scratching at his skin or his wrist. What personality disorder is this? It's literally borderline personality disorder. That's it. Very easy to find it. He has unstable mood, he's suicidal, and he's doing impulsive things. Borderline personality disorder, right? A 21-year-old college woman complains of a feeling that something is stuck in her throat. She generally describes her friends in 3 words or less. She moves from excessive crying to laughing during the interview and describes feeling happiest when she is the center of attention. What personality disorder is this? Well, they gave it away in the question when they said she likes to be the center of the attention. This is histrionic, right? Excessively emotional and attention-seeking, theatrical. The questions are going to put more into them. It's not going to be this small though. These were tiny questions. You're usually going to have big questions about a bunch of shit. You're going to have to pick the most key root thing to define what is actually happening. And time periods are going to be big. If something's been happening forever and has been a part of their life for the longest time, and that's how they've always been, then it's some personality disorder, and you need to find the root trait that defines that one personality. Okay? And if it's not a personality disorder, then there's going to be a smaller time period of something more acute that happened, and you'll fit it into another diagnosis at that point. Right? And then here you just have all your defense mechanisms. This is a very short summary of the defense mechanisms. In all reality, each time you read this list of vocabulary words, you're going to feel very good and you'll know what's happening. But it actually is very easy to forget them and confuse them and then completely mess them up. Right? And that's something that you do not want to do. So when we did our step 1 psych videos, we talked about them and came up with pretty nice mnemonics and stuff to actually get them down. Now, for the mature stuff, there's only 4. There's only 4 mature stuff, and that's sublimation, altruism, suppression, and humor. And you'll see when you look at them that these are things that you would never say is an immature way of dealing with something. These are actually okay and acceptable, mature ways of dealing with something, where you actually lead to some kind of hopefully good result. So starting from the top, first one, immature, acting out. Obviously an immature thing to do. Subconsciously coping with stressors or emotional conflict using actions rather than reflections or feelings. Right? A patient skips therapy appointments after deep discomfort from dealing with his past. Acting out is something we've all done as kids. We wanted candy, we didn't get it, we started yelling. Right? That's kind of what's happening there. Denial, very immature thing because that's not going to lead to good results. Avoiding the awareness of some painful reality. A patient with cancer plans a full-time work schedule despite being warned of significant fatigue during chemotherapy. Right? Being in denial is also extremely common ego defense because the news is so bad you don't want to accept it. But not accepting it is not going to lead to good results. That's how I define things to be immature. Displacement, redirection of emotions or impulses to a neutral person or object. You're displacing your anger and thoughts or whatever it is, your emotions, to something like a wall, right? Punching the wall in your anger. That's displacement. A teacher is yelled at by the principal. Instead of confronting the principal directly, the teacher goes home and criticizes her husband's dinner selection, right? Although I don't find this to be the best example, the husband is theoretically a neutral person or object, but most commonly you'll see this being done either in this manner or the punching a wall, breaking a keyboard, these kinds of things. Again, very common thing. Displacement, for example, is very common in big time video gamers. You'll see they'll be playing their video game, things went bad, they lost, they'll smash their keyboard, break their mouse, silly things like that. People watching football games, and then the football team they were rooting for lost, they'll pick up and break their expensive ass huge TV. That's all displacement. Immature things people do just because it makes them feel better. But does it lead to good results? No. So that's how you define, at least that's how I define immature ego defenses, right? You do it because it makes you feel good, but there's no positive result coming out of it. Dissociation, temporary, drastic change in personality, memory, consciousness, or motor behavior to avoid emotional stress. We saw dissociative symptoms as well. So this is related to that. A victim of sexual abuse suddenly appears numb and detached when she's exposed to her abuser, right? Because she doesn't want to go through PTSD, nor does she want to go through those thoughts again, and a bunch of other stuff. Fixation, not growing up. That's all this is, right? Partially remaining at a more childish level of development. A surgeon throws a tantrum in the operating room because the last case ran very late, and I'm glad they chose this. If any of us ever become a surgeon, I'm not going to be a surgeon, I don't think so, but if I ever do, I'd love to see if I become a person that throws tantrums, because this is actually pretty valid. Surgeons are pretty retarded people for the most part. They just go off with their immature, childish behavior and very narcissistic attitude at a lot of times. It was the one thing that I think most of us may have seen during rotations, and it always sucked. If you had to do your surgery rotation under a surgeon that was really narcissistic and egotistical and retarded and stupid, then it was just like, what the fuck, man? You make all this money and you're so successful and you want to act like a little baby? That's what this is. Fixation. You stay at that age, right? You're going to be comparing this to something called regression later on. We'll see that later. Idealization. This, by the way the word is written, you can tell you're taking something and you're making it ideal, right? So it's an idealization. Expressing extremely positive thoughts of self and others while ignoring negative thoughts. So you're taking someone and making them into a very ideal person. We do this every day, or at least all of us have done it at some point when we fall in love. We find someone we fall in love with. They may have flaws, but we disregard them to make them look like the ideal love partner by only really focusing on the things we like about them, right? A patient boasts about his physician and his accomplishments while ignoring any flaws, right? So this is a patient making his physician an ideal physician, even though the ideal physician may have many lawsuits or something pending on them, right? He's ignoring those things. So these are, again, immature, because if you're ignoring flaws in your love partner, or if you're ignoring flaws in your physician, then you're overlooking things that may actually be significant, and this may lead to problems, right? It happens every time. We meet someone brand new, we start dating them, we ignore all their flaws because we're so excited about this new relationship, and then all of a sudden you ignored some critical flaws, and that led to problems down the line. Identification. Largely unconscious assumption of the characteristic, qualities, or traits of another person or group. So, by the way this word is written, it basically means you are taking on the identity of someone. Identification is theoretically, in a sense, identity theft, right? So, a resident, a brand new resident, starts putting his stethoscope in his pocket like his favorite attending instead of wearing it around his neck like he did before. So, he's acting like his favorite attending, right? This is like imitation in a sense, or think of it as identification theft. This is also immature. Just by acting like someone, you won't become that person. Now, acting like someone is pretty good way to begin, like becoming that person, but you actually have to make their achievements, right? And that's the only way I can explain that. But generally speaking, you want to come up with good conversation for each of these and good examples for each of these, so it sticks to you forever. Like I'm trying to give you one for each one of these. Isolation. So this is actually isolation of affect, which means you're getting rid of all your emotions, separating feelings from ideas and events. So you're describing a murder in graphic detail with no emotional response, describing your rape event without going into any kind of tears, right? Describing what you saw without really going into any kind of emotion. So it's a separation of the two things. Bad things happen, but you're showing no emotions about it. Now, this is also immature because if you don't attach the emotions to it, then you'll never get over it. Right? You need to get through the mourning and the crying and the depression or whatever to finally get over whatever that big incident was. Passive aggression, one of the most common things we used to see at work every day before the pandemic and before things became remote. Demonstrating hostile feelings in a non-confrontational manner, showing indirect opposition. Very immature. It's just going to piss people off, and then you're probably going to get an aggressive, passive-aggressive response back, and it's going to be a never-ending story, which may end up at HR soon. A disgruntled employee is repeatedly late to work, but won't admit it is a way to get back at the manager. It's stupid. There's no point in doing that. That's not going to resolve anything. It may probably just end up getting fired, if anything, right? Projection. We just talked about this one. This is where you project your own thoughts onto someone else. So you're the one that wants to kill somebody, but you go up to that person and be like, hey, you want to kill someone, don't you? You may want to rape a woman, and then you tell your friend, oh, wow, you want to rape her, don't you? That's projection. It's like being a projector, a film projector. You're projecting yourself onto someone else, right? Attributing an unacceptable internal impulse, like wanting to rape somebody, to an external source. A man who wants to cheat on his wife accuses his wife of being the cheater. Right? He's projecting his own mentality onto her. A child angry with his parents' divorce decision falsely thinks his parents are actually angry with him. Right? So many different ways to present this topic. Just got to make sure that you're seeing this mirroring thing that's occurring, right? A mirror is a projection of you. Rationalization. This is, by the way the word is written, taking something and rationalizing it. But you're rationalizing something really stupid. Asserting plausible explanations for events that actually occurred for other reasons, usually to avoid self-blame, which is, of course, immature. You need to accept what happened and move forward. After getting fired, claiming that the job was not important anyway. This is also seen in patients who get a really bad cancer diagnosis, and they'll, instead of accepting it, they'll be like, well, cancer only kills 1 in 10 people, blah, 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 and they'll try to make up all these reasonable things to explain why they don't think they'll die. Reaction formation. So remember the concept of every action has a reaction. This is basically that. Replacing a warded off idea or feeling with an emphasis on its opposite. Right? So that's what the reaction is. A patient with lustful thoughts enters a monastery. Right? Reaction. I wrote here reaction formation, physics, Newton's third law. Every action has an equal and opposite reaction. So the person is unhappy but chooses to show happiness. That's what you're going to see here. Right? So reaction is the opposite reaction. This is also immature because the person is unhappy. You need to deal with that, not act happy. Right? Deal with what you're unhappy about. Regression. So this was in comparison to fixation. In fixation, you're fixed. You're not growing up. In regression, you grew up and went back to being childish again. Involuntary turning back the maturational clock to earlier modes of dealing with the world. Seen in kids under stress such as illness, punishment, or birth of a new sibling, right? Bedwetting in a previously toilet-trained child. So again, this is also very common and obviously not a good thing. Repression. So this is also going to be something you're going to have to compare with suppression later on. Repression is involuntarily withholding an idea or feeling from conscious awareness. A 20-year-old does not remember going to counseling during his parents' divorce 10 years ago, right? So this is you kind of involuntarily forgetting something. In suppression, you'll see it's intentional because this is mature. So we'll get there. Last thing here is splitting, which was related to borderline personality disorder, believing that people are either all good or all bad at different times due to intolerance of ambiguity. Right? A patient says that all the nurses are cold and insensitive, but all the doctors are warm and friendly. This is something that they do because they don't like ambiguity. They don't want to say, well, yeah, he's good in this, but he's bad in that way. They don't like that. So now, first thing we'll compare repression and suppression. So repression was involuntarily forgetting something. In suppression, you intentionally withhold an idea or feeling from conscious awareness. It's temporary, right? Choosing to not worry about the big game until it is time to play. Common thing you do. There's no problem with it because remember, this is actually good. If you stop worrying about it, it's actually good. You might actually get somewhere with it because what's the point of worrying if it's not going to achieve anything, right? Sublimation. So sublimation is related to reaction formation. So reaction formation was Newton's third law that every action has an opposite reaction, right? Equal and opposite reaction. So we saw people that were unhappy acting like happy people. Here, this is sublimation. This is also a physics term, chemistry term as well, mainly physics. This is the phase change from gas to liquid. When something gas becomes liquid. We see this all the time when we're cooking and we put the cover on top, that the gas that's forming inside the pot makes liquids on the underside of the cover. That is sublimation. A phase change doesn't change what the thing is. It was still water as a gas and it's still water as a liquid now, right? So phase change from gas to liquid, but the molecules are still the same, not the opposite anymore like it was in reaction formation. So a person is still angry, but they use it appropriately because this is the mature ego defense. Replacing an unacceptable wish with a course of action that is similar to the wish but socially acceptable. For example, a teenager's aggression towards his parents because of their high expectations can be channeled into excelling in sports, or joining a gym, or buying a punching bag, stuff like that. Acceptable things. Okay. Altruism. This one is also related to reaction formation. So remember, in reaction formation, you kind of did the opposite, right? In altruism, you alleviate your negative feelings via unsolicited generosity. Right? So I wrote here it's very similar to the immature reaction formation, but in reaction formation, the good deed is not planned or consciously acted out. Both people are doing a good deed to wash the bad deed away. But here, this is a planned out thing. A mafia boss makes a large donation to charity because he's a mafia boss and unconsciously or somehow he feels bad about what he does, right? So I came up with this thing too, alternate truth, right? Alt-truism. There is an alternative truth to the character of this person. In the example, he's the boss of a murderous mafia but presents himself as a philanthropist. Right? So all of these are, both of these, sublimation and altruism, are related to reaction formation, but only reaction formation is immature. You are very upset about something and you do nothing about it. Instead, you act like you're happy. That's not going to solve anything. Right? Here, these people, it's not necessarily going to solve anything, but it doesn't worsen it either. They actually feel better and things are good and there's no harm in what they're doing. It's acceptable, socially acceptable behavior. The last one is humor. A nervous medical student jokes about the boards. Something stressful is happening, and instead of accepting that it's stressful, you lightheartedly express uncomfortable feelings to shift the internal focus away from the distress so you can arrive at it later. It's not an immature thing. Humor is a mature way of dealing with the problem. Right? And that's it for all of that. That takes care of all your ego defenses that you may see in multiple places. And then in our next video later tonight, we'll move on into substance use disorders.